Hey, welcome to the final cardiology topic on antiplatelets and anticoagulants and a couple other random things quickly. So the big focus of this topic is going to be talking about blood clotting and the ways we can manipulate it. So there's two kind of major different ways that blood clots, and the whole purpose, the two pathways work together, and the purpose is to prevent the flow of blood. So sometimes this is good, right? If we're helping healing tissue, or if there's damage in a particular area of the body, the clot can help seal it off so that the tissue can heal itself, and eventually the clot kind of dissolves and disappears. And that's fine, especially externally for external trauma or damage. Internally, in blood vessels, this gets complicated. So that's why we need to make sure we're following specific guidelines and treating appropriately depending on the indication. So I like to break it down into red and white clots. It's a somewhat oversimplified way of looking at things, but I think it works for me. So here's what I want to talk about. For a red clot, this is basically a clot that involves red blood cells. It's fibrin rich. And I think about this as a slow-moving blood area. So places where blood can pool, like in the extremities in the veins, like a deep vein thrombosis, for example, or in places like the heart, if there's fibrillation going on. So if there's atrial fibrillation, the atria aren't pumping regularly, they're just kind of quivering. The blood is simply just sitting in there pooling. It's not moving as fast as it normally would. And that's where you get red type of clots. White clots are platelet rich, and they're usually in more fast-moving areas. So we think of these as being causes of blockages in like the coronary arteries, where the blood is generally pumping through regularly. It's moving really fast, but if there's tissue damage, the platelets are going to aggregate to that area and cause a clot. It's usually not a long enough period of time to form a red clot too, although it certainly can happen as well over time, depending on how big the clot is and how long the clot goes without causing a major infarction. So that's kind of how I break it down. Pharmacologically, we treat each side differently. So that's where I want to start with, just talking about that background. This just shows it more as a diagram, obviously, but what I was talking about here is, and what we talked about with cholesterol, you have a cholesterol plaque that develops in the arterial wall. Eventually, it sort of gets large enough where it can break through tissue into the lumen space, and then you end up with internal tissue damage. You get platelet aggregation, which ultimately slows blood flow enough to recruit red blood cells as well. You get fibrin formation and a clot, and ultimately the artery gets blocked to a substantial degree or completely. All right, let's talk about platelets first. Platelet biology has to do with, when we talk about clots and platelets, we're talking about compromised integrity of the vascular lining. That's really our biggest concern here, whether that's in the heart or the brain or somewhere else. But those are kind of the two major areas we're looking at as far as preventing things from happening. Platelets will be exposed to collagen fibrils. They provide a surface for adhesion, and that stimulates platelet activation and recruitment using different signaling pathways. There's a couple of signaling pathways that are prime drug targets: adenosine diphosphate and thromboxane A2. Might sound familiar from our previous lecture where we talked about thromboxane, but we'll come back to it here in a second. These things are secreted by platelets, and again, they'll activate and sort of act as a recruitment system for other platelets to link up together. The platelets connect via circulating fibrinogen, and there's specific receptors called GP2A3B receptors, and these are where the platelets link together. So again, that's another drug target. This is a less common option. There's really only one drug that works like this. Well, there's a couple, but they're all kind of the same. There's like 3 in one class, and they're only really used in specific situations, so don't worry too much about that. But the other thing to know about platelets is that they have a 5-day life cycle. So whenever you stop somebody's antiplatelet, it takes about, I think we safely go with a whole week, so about 7 days to really get enough circulating platelets back. So that's important if you're going to have somebody hold an antiplatelet agent prior to surgery or something of that nature. This is just a diagram kind of explaining what I just talked about with the different receptors and the platelets. Okay, the different drugs we have to treat or to use to manipulate or stop this process from happening. Aspirin, the old standard, which is still the most commonly used antiplatelet agent out there. It's a thromboxane A2. thromboxane A2 is produced via the cyclooxygenase pathway, as we talked about in the previous lecture. Aspirin works upstream by preventing arachidonic acid from working and spreading out and causing cyclooxygenase and lipooxygenases to activate. So you don't get as much thromboxane production. Therefore, you get platelet inhibition, or the inability to recruit and form new platelets. P2Y12 inhibitors, or ADP inhibitors, prevent the interaction of adenosine diphosphate with G protein coupled receptors. So that's a different mechanism. So these two do kind of the same end game, but they work very differently. So oftentimes they're used in combination if you have a high-risk patient. And we'll talk about those situations here in a little bit. The GP2A3B inhibitors inhibit that final common pathway of platelet linking. Again, they have a less broad role in medicine, but they do have some use, which we'll talk about. You're probably only going to really see these used if you work in interventional cardiology. But other than that, they aren't really used in primary care. They're mostly for acute care type stuff. Cyclic AMP interference. Dipyrimidol is a drug that can raise cyclic AMP levels, and this is a drug that has a bit of questionable efficacy. It's mostly used in stroke care for certain patient populations, so we aren't really going to talk about with respect to cardiology. We'll come back to it during the neuro module a little bit when we talk about stroke. And then there's thrombin receptor antagonists. These are drugs that are new that don't well, I should say they're investigational drugs that are new and possibly coming out, but they aren't really existing at this point. The only one that was almost out was this Vorapaxar, which wasn't found to be beneficial in increased bleeding with percutaneous coronary intervention. So that's not something we like in these patients specifically. So that went back to the drawing board, and we'll see if any others come out in that class. But for now, we don't know. We're really just stuck with these two. Aspirin and the P2Y12 inhibitors are really the two major drugs in this category. The rest of these are less applicable to what we're talking about. And this just shows a platelet with the different kind of drugs pointed out. We'll talk about ticagrelor, cangrelor, clopidogrel, prasugrel, etc. All right, aspirin. So remember, this inhibits platelet activation via suppression of thromboxane 2. It's most often given as the baby aspirin dose, which is kind of a misnomer because it's not used in babies. In fact, aspirin is potentially toxic and problematic in children for a couple of reasons. But a lot of people call it the baby dose, or baby aspirin, and it's 81 milligrams. Or there's full-strength aspirin, which is 325 milligrams. The nice thing about aspirin used for antiplatelet effects is that low doses produce good results. High doses don't necessarily improve. There is some data that in certain populations it's better to use high-dose aspirin, but you can get by with the platelet inhibition effects with a low dose of aspirin, which is good because aspirin tends to have some issues with especially dyspepsia and GI-related side effects if you take large doses of it. I think people also associate aspirin as a pain medication, but most people don't use it for pain. You have to take fairly high doses of it, and it's simply not as good as ibuprofen or naproxen or some other medications like that. So sometimes with the 325, you might see this used again for chronic treatment in certain cases, but most often patients are going to be on the 81 milligram. The 325 is sometimes used as a loading dose, so if somebody comes in with an active heart attack going on, they'll be given aspirin. Usually EMS gives them that in the ambulance on the way to the hospital. And non-enteric coated can be important for this, so having chewable aspirin available for the patient. If you're like ordering something in an ER or urgent care, you're always going to pick the chewable type if it's acute. And then ongoing therapy is generally speaking 81 milligrams, but there might be some people like post-CABG, which is coronary artery bypass graft. So that's a cardiac bypass procedure. Sometimes they'll use higher doses for those patients. And there's some stroke patients that will use higher doses occasionally too, which we'll talk about during the stroke lecture. It is available as a suppository, so if somebody is unconscious, can't tolerate oral medication, you can give it quickly that way, and it does have good absorption rectally. Lots of inappropriate use. I say that because I think there's a lot of advertisements about aspirin and how it can protect your heart, and people, it's over the counter, so people might just take it because they think it's good for them. In fact, there's actually studies out there that say if you don't really have a specific indication for aspirin, and even some preventative indications, the benefits don't outweigh the risk, because aspirin does increase your bleeding risk. So if you fall or get into an accident or something like that, you can have significant trauma complications because you're on an antiplatelet agent, and especially if you don't need to be, you really shouldn't be. So if you ever see a patient on an aspirin daily regimen and they don't really have any other indications that make sense for that, like maybe they're on some antihypertensives and that's it, it's probably something to question. Why are they taking that? All right, so primary prevention with aspirin is for over 50 with a 10-year risk score greater than 10%. We talked about our risk scores during the hypertension lecture. So that's a 10-year risk of some sort of a cardiac or neurological stroke type event within 10 years and being over the age of 50. Then you're recommended to be on an aspirin. So that might be an indication where if your patient's 75 and they're otherwise healthy, technically they might qualify for an aspirin. Now that's a little bit complicated because maybe they don't really need the aspirin, and so that's where I think some of these guidelines get a little convoluted, or people don't always follow them because, like, my 70-year-old's healthy, I don't really need to give them an aspirin. They're at higher risk for falling and having a problematic bleed than they are for a heart attack or something like that. So that's something to consider. But technically, yeah, over 50 and your 10-year risk score greater than 10%, you would qualify to take an aspirin. Post-acute coronary syndrome and patients requiring anticoagulation who are low risk as well. And then I talked about stroke already, which we'll talk about during the neuro module. So the biggest side effect with any time you're manipulating platelets or the coagulation pathways, you're going to be increasing bleeding risk, which is going to be risk in case somebody has a significant accident or is undergoing emergent surgery. It can make things really complicated as far as do you reverse them, do you deal with the bleeding risk, how do you do that? Dyspepsia I talked about, GI ulceration, just like any non-steroidal anti-inflammatory agent. These aren't technically NSAIDs, but they kind of work on the same pathway, so they can decrease those good housekeeping prostaglandins and prostacyclins that we like in our GI tract, possibly put people at risk for that. They're very aspirin is really toxic in overdose, so that's a one thing to consider too, especially in mental health patients. And it's contraindicated in children less than 16 years old. There's something called Rey syndrome, which is an encephalopathy that's associated with viral illness and aspirin use. Really, really rare, and whether or not it actually is completely linked to aspirin, I think that still is technically debatable depending on who you talk to, but it's been widely associated with aspirin for quite some time. The Agrinox combination, again, is a stroke prevention only, which I won't talk about here. We won't use that for this particular module. We'll come back to it during stroke, so you don't have to worry about dipyridamole at this time. All right, let's talk about our P2Y12 inhibitors. P2Y12s, the most common one and the oldest one is clopidogrel or Plavix. I talked about Plavix really briefly, if you remember, during the very first set of lectures when we talked about prodrugs, because Plavix is kind of a hallmark prodrug. It needs to be activated by certain CYP enzymes and converted. All these P2Y12 inhibitors have loading doses and daily doses. I don't want you to know the doses, but know that in certain situations, and refer back to the acute coronary syndrome lecture, you give a loading dose and then a maintenance dose. So with clopidogrel, we do a load acutely, depending on how emergent it is, and then they go on a maintenance regimen, and that's how all these drugs are. Okay, so the prodrug. One thing to remember about clopidogrel is that it is a prodrug, first and foremost. The big thing about that, and this is probably one of the areas where pharmacogenomics has been most incorporated, is people get genetic testing done for Plavix, because these drugs are really important post-acute coronary syndrome, so we need to make sure that they're working. And if we give them to a patient who's a poor metabolizer, they might not convert enough of that prodrug into the active form to allow for therapeutic benefit. And if that doesn't happen, they're going to end up back in your cath lab with another MI. So this is one where they will test specifically for polymorphisms within the cytochrome P450 system, the 2C19 and 3A4 specifically. Remember, 3A4 is one of those really big popular ones. 2C19 is a relatively popular one as far as our overall drug metabolism goes. So the point of this is that genetic testing, you might see this done for clopidogrel, and people might be switched to a different agent if they don't have some active metabolism in those areas, I should say. Proton pump inhibitor interaction. This was a big controversy a while ago, and maybe I should just delete this because I feel like no one cares anymore. But I think it's an interesting story of just how things can happen and conversations that can come up about this stuff. So with Plavix, what happened is, first of all, proton pump inhibitors, Prilosec, Protonix, Nexium, are some of the most popular drugs on the market. Tons of people, millions of people take them. And when a study came out that said, somebody looked into it and said, well, their hypothesis was these drugs actually inhibit the enzymatic activity of 2C19, especially Prilosec, which is omeprazole. So people taking omeprazole or Prilosec were technically inhibiting their enzymes. So there's this big controversy, and people found that the levels of Plavix were significantly lower in these patients than they were in other patients. And remember, you're inhibiting the enzyme, therefore the prodrug can't be metabolized into the active form. So in this case, we want a first stage metabolism. You want that enzyme to be active, metabolizing that into its active form. In this case, it was inhibited by Prilosec specifically, and Nexium to a certain degree. Protonix doesn't really do it as much. It works on some different enzymes. So no one ever thought this was an issue until somebody studied it and said, hey, it's a big deal. Fortunately, in subsequent trials, they found that it doesn't really matter. There were a couple years there where everyone who was on clopidogrel was being switched off of a proton pump inhibitor and onto a drug like a histamine 2 blocker, like ranitidine or famotidine, just because those don't have the same interaction profile. But there is some subsequent evidence which I would argue isn't great, but it did come out and say, yes, this does happen. It does decrease the overall concentration of clopidogrel, but it's not clinically relevant. There weren't any differences in clinical outcomes with that. So you might see providers be hesitant to prescribe these together. It probably depends on the cardiology practice and just the provider's personal preference, but a lot of this has kind of gone by the wayside, and people don't really care about this interaction anymore. But it was a really big deal for a couple of years. Clopidogrel is also the lowest percentage of platelet inhibition, and therefore it also has the lowest bleeding risk. So it's the safest of the three, but it's the least potent. But that doesn't seem to affect its overall potency. It's still not an inferior drug compared to the other two. So take that for what it's worth. It's also been generic for the longest period of time, and therefore it's the least expensive of the three medications. Prasugrel is the second P2Y12 inhibitor, probably the least used. Effient is the brand name. Again, loading dose and maintenance dose are there. This is another prodrug, but it has a ton of different pathways to get to its end point, so it's really not prone to drug interactions or genetic issues, because if somebody has some polymorphism, they probably have another pathway the liver can use to metabolize that into the correct form. It's the longest lasting. There's a lot of active metabolites, which makes it risky to use in older patients, just because they generally metabolize, process, and eliminate medications slower than younger patients. So that's why there is a recommendation to decrease the dose to 5 milligrams if you're over 75 and under 60 kilos. Actually, weight has something to do with it as well. Generally, smaller people don't metabolize quite as fast as larger people, or if you give the same dose to, they're going to keep it in their system a little bit longer. This one's got some interesting contraindications, especially since it's noted as the one with the highest bleeding risk. It is contraindicated if you have a history of a stroke or transischemic attack. There's some evidence out there saying that this maybe doesn't have the bleeding risk that people say, but for now, this one's technically considered the most risky of the P2Y12 inhibitors. Ticagrelor or Brilinta is the newest agent. It's 180 milligram load with a 90 milligram BID maintenance. This is the only one that's BID, which makes it a little bit less convenient daily dose than the other ones. This is an interesting drug for a number of reasons. It's not a prodrug, and it has reversible binding. So it may require less holding time to get rid the body of its effects. And it has some 3A4 metabolism, but it's really not prone to drug interactions like the other two, or at least like clopidogrel, as I should say. It has the highest percentage of platelet inhibition, and to the fact where we don't use it with aspirin 325 for maintenance. So even if you had an indication for aspirin 325, like if you're post-cabbage, you would still only use the 81 milligram because the bleeding risk is quite high with ticagrelor. In fact, there's a few studies out there that show that even though ticagrelor is potent and has good outcomes overall from preventing heart attacks and things like that, it actually has higher bleeding risk compared to clopidogrel long term. So a lot of people don't use this one for a long period of time. However, the big use of this is in the acute phase. It's got the fastest onset of platelet inhibition, and it's potent initially. So this is our go-to drug for acute coronary syndrome. So if somebody comes in with a heart attack, unstable angina, whatever it might be, well, I shouldn't say that. If they're coming in with a STEMI, basically, that's the situation where they get ticagrelor right away because you need to get them to the cath lab immediately. If they are coming in with an NSTEMI and you're going to admit them to OBS, you can probably just do a clopidogrel load, wait for it to take over because you're going to have plenty of time because they're probably going to go into the cath lab the next day. So those ticagrelor is really useful in acute high emergency situations. Other than that, we don't use it very much just because it is a higher bleeding risk than the other ones. So we do have a little bit of a problem with it from that perspective. But it definitely has a role, and it is our go-to drug for those STEMIs. Here's just a comparison of indications, half-life, metabolism, those types of things, in case you want to look at it. Okay, switching gears a little bit from platelets to anticoagulants. This is the clotting cascade pathway. And so every drug we're going to talk about from now on, now that we've moved on from our platelet agents, is going to work in this area. You notice there's two branches to the pathway. There's intrinsic and extrinsic. Extrinsic is basically just a source of trauma. So something's injuring something, and there's tissue factor that's immediately activated, and it goes right to the common pathway fairly quickly. The cascade on the intrinsic side is different. There's a number of different things that happen with the damaged surfaces, and yada, yada, yada. You eventually get to the common pathway. Why don't I care about this as much? Because the common pathway is really key for drugs. All of our drugs that work as an anticoagulant, if it's going to be effective, it's going to work factor 10 and or factor 2, usually both. So we really just care about this middle pathway. That's going to be the ultimate kind of make it or break it. We need a clot to form. If you inhibit it, we can't do it. If you inhibit way up here, that doesn't really help you as much if you have like an extrinsic issue going on. So same thing on the other side. So we have to look at our drugs that way. But most of the mechanisms of action for anticoagulants are pretty straightforward. They basically work to inhibit these either by binding to the receptors directly to stop them, or they bind to the actual product to prevent it from doing anything more. Okay, so these are our red clots we're targeting. If we go back to my terminology, medications, again, target that common pathway, and we want to prevent synthesis of the active clotting factors. There's a lot of different products available: oral, IV, sub-Q, fast-acting, short-acting, long-acting. There's a lot of reasons why we anticoagulate patients but basically they all kind of stem from we need to prevent clots from growing, whether that's in the atrias of a fibrillating heart, in the deep on the venous side, in the lungs, or in the extremities. If we're following up, some acute coronary syndrome patients might be on an anticoagulant, depending. It's rare. They're usually on an antiplatelet, but you might see that done occasionally. And status post-ortho surgery, a lot of times these are used as well, although that's been more favored to just aspirin instead. One thing about anticoagulation as well, requires frequent monitoring for most of these. However, there are some newer ones where we don't technically monitor them, but that doesn't means you might not get a lab value, but you still want the patient to be monitoring signs and symptoms of clotting or bleeding, because these are the highest risk drugs we probably give patients. And there's actually some studies out there that say that the majority of drug adverse event related emergency department presentations are either due to anticoagulants or drugs that lower your blood sugar, hypoglycemic agents. So these are definitely what we'd consider high-risk medications. Okay, talk about heparin first. Heparin is sometimes referred to as unfractionated heparin, or just regular heparin. That's exactly what this is. So heparin, what it does is potentiates antithrombin, which then complexes to factor 10A, preventing the formation of factor 2, which it also inactivates factors 9 and 10 and prevents the formation of fibrins. It's got a few different mechanisms. You notice the vast majority of these things fall within that common pathway. So that's our important part. Heparin's been the gold standard anticoagulant for a number of conditions for decades, and it's still very well used today. It's one of our primary inpatient IV products. There's also some subcutaneous use as well. But usually with subcutaneous use, if we're just doing a sub-Q injection, it's probably prophylactic standard dosing. Otherwise, for IV heparin, if we want therapeutic anticoagulation, you're doing a weight-based dosing schedule, targeting specific levels and testing every so often. So this requires really frequent monitoring. The nice thing about heparin IV is it's really easy to do from a provider perspective because all you have to do is order it. You just order heparin protocol, and that signals an order to pharmacy. We complete it, check it out, make sure it looks good, send it on to nursing, and nursing does all the lab checks and monitoring and changing of rate from then on. Effects with heparin are basically immediate if you give it IV. So if you want somebody anticoagulated quickly, this is really the drug you're going to use. This is pretty much the only drug you're going to use. There's a couple others, but this is your primary one. You're going to monitor APTT or anti-10A activity and adjust your dose accordingly. Different sites might prefer different ones. It's all the same thing ultimately, but we use APTT, for example, but who really cares? It's one lab, and protocols are all based on that lab. So you might go to Alina and they use APTT. Fairview might use anti-10A, but they're going to have protocols based on those specific levels. The half-life is really quick. It's about 1 to 2 hours, so it leaves the system quite fast, which is nice. If you overdo it, you don't have to wait a day for your heparin to wear off and worry about your patient being at high risk for bleeding for that long a period of time. It'll go away fairly quickly. And the other really nice thing about heparin is there's no renal adjustment needed, which is a huge boon. And since so many drugs require that, we could use this in our renal failure patients without much issue. Heparin production is kind of an interesting one. It's actually, this column A here is how most heparin is made. They use intestinal lining from pigs. So if you look at a heparin vial or bag, it'll say porcine on it because it's from pig sources. They process and fractionate the intestinal lining. They kind of, probably spin it down until they get the right molecular weight they want, and then they dry it up and put it in a powder and mix it in IV bags or whatever they need to. But that's basically the science of heparin. There are synthetic and other ways to make heparin, but they're really expensive and just not as easy to do as this. So in countries with large pork processing, that's a byproduct of pork that's valuable for those farmers who are processing pigs, and so that's where they use it. Now, one thing to remember is that some people will not have pork products of any kind, depending on specific religious preferences, usually is what we see. So they might decline any type of pork heparin-related product. So that's one of the reasons why I go into this, in addition to just being kind of an interesting, quote-unquote, natural product. All right, so heparin, just as an example to talk about what this might be. So let's say you come into the hospital and you have a new DVT. Or something. This dosing is kind of generic because it changes. So like a DVT actually might be a little higher, where they do an 80 unit per kilo bolus, and then they do like an 18 unit per kilo. That's an example. But again, this is sort of just generic dosing on like where people start. So initial loading dose, 80 units per kilo, given over 10 minutes, followed by your maintenance dose, 80 units per kilo per hour. Adjust your APTT. We target a 60 to 85 second. Again, this could change. You might have a lower potency protocol, or even maybe higher in some cases, depending on your institution's practices, but this is sort of general again. And then I gave you the conversion of the anti-factor 10A level there in case you're curious. You do not need to know this stuff, but just for the record, if you're wondering what these labs are. Adjust your rate by 10% up or down, and hold and rebolus if you need to. So you might overshoot your goal right away and be like, wow, this patient's really heparin sensitive, and their APTT came back at 110. Okay, well let's ramp that down. Or maybe we hold it for an hour and then start at a lower dose. Or maybe it's really low and they aren't responding. Well, let's give them an extra bolus. So there might be protocols might direct the nurse to do different things. Ultimately, there's my least favorite part of the protocol, which is this patient doesn't make any sense, call pharmacy and have them figure it out. Because I don't do a lot of heparin dosing myself, so my favorite thing is when I'm staffing in our main pharmacy in the evening and the weekend, and I get a phone call from a nurse about, this is asking me to call pharmacy because it's not figuring out what to give. I'm like, oh, great. And so fortunately, you can work these out. And again, heparin doesn't last very long. So small adjustments, you should see the effects of them relatively quickly. So that's the nice thing about working with heparin, is you see effects without having to wait or worry about, well, if I overdo it a little bit, it's not going to last very long in their system. Therefore, they're going to be at a lot lower risk for bleeding still at risk for bleeding, but again, it's gonna wear off a lot faster. One of the biggest things about heparin that's sort of notorious and really rare, fortunately, is something called heparin-induced thrombocytopenia, or HIT. This is defined by a precipitous drop in platelets 5 to 19 days into therapy. The way you treat this is you stop heparin immediately. You don't re-challenge for at least 100 days. And the maybe counterintuitive thing is this actually increases your chances of clotting. You might think, well, a drop in platelets should increase your bleeding risk. But what happens is heparin, your body actually develops antibodies to heparin. It complexes with the heparin, forming this compound that interacts with platelets and activates them. So what's happening is you're activating all these platelets, and that actually kind of modifies the platelet so that your lab value won't pick up that platelet anymore. It's basically gone at that point. So once it's activated, it is activating a bunch of other things, and then it causes clotting in some areas. So actually you can see this really graphic picture here, sorry about that, is an example of what HIT can do to patients. Kind of causes this massive amount of necrosis because all this tissue has been clotted off due to HIT. So HIT can be really dangerous. Certainly this type of an event is highly problematic, but more so, if you think about issues within the coronary vasculature, cerebral vascular, stroke, MI risk, it can be fatal. So monitor platelets regularly on patients on heparin. That's a requirement. And if they've had HIT in the past, make sure that you're looking at your challenges and whether or not it's worth re-challenging, and specifically making sure that they're within like 90 days, 100 days out. All right, another form of heparin is low molecular weight heparin. So again, we have regular heparin or unfractionated heparin, and then we have low molecular weight heparin. Low molecular weight heparin is basically the same thing as heparin. It's just a smaller molecule, and it interacts with the clotting factors a little bit differently. There's enoxaparin and dalteparin that, again, act very similarly. They have a lower incidence of HIT from the get-go. However, if the patient has had HIT, you don't give these to them. You'd give a different product altogether. Really mostly targeting factor 2 and 10. Again, mechanism is very similar to heparin. And we usually don't do any monitoring for this. So with heparin, we monitor that APTT pretty religiously. With these, it's usually a set it and forget it. It's weight-based dosing. The kinetics are relatively predictable. It's based primarily on renal function, which is interesting compared to heparin, which is not. So that's one of the biggest differences. You dose it based on weight, renal function, every 12 hours, and that's all you really have to do. There have been some studies looking at lab monitoring, and we used to monitor these, which was super annoying because there's never any really good science that monitoring enoxaparin levels does anything therapeutically beneficial to the patient because, again, the kinetics are predictable. So just going with the way that the manufacturer recommends dosing is really all we need to do with these. There are some titration levels you can do. You can get factor 10A levels and things like that calibrated to enoxaparin or dalteparin, but overall it's not going to be done commonly. And specifically enoxaparin is going to be the drug you're going to see vast majority of patients on. Dalteparin is not as common. Enoxaparin has been around longer. It's kind of comes in a quasi-generic form. It's not cheap because it's a packaged sterile syringe. It looks like this. So it's not like it's a tablet somebody can take, which can be mass-produced for pennies. But this particular product is still kind of expensive, but it is at least have a generic equivalent with it. The uses for low molecular weight heparin, probably most popular is as a bridging therapy. So we'll talk about warfarin here in a second, but warfarin takes a few days to start working, and low molecular weight heparin works within a couple hours. So if you have a patient who you want to start warfarin on, but they aren't going into the hospital, you can start them on low molecular weight heparin and warfarin, and then in a few days, hopefully their warfarin's therapeutic, and you can pull back that low molecular weight heparin so they aren't injecting consistently. Otherwise, you can use this in substitution for any other anticoagulant. So you could use it as a treatment option long-term if you needed to. But a lot of patients, because it's injected in the abdomen, they end up with just a bruised abdominal area because of that local effect just stays there, and you get kind of some bruising that's superficial. It's not like you're bleeding internally, but it's really common. So a lot of patients don't like that, and a lot of patients don't like injecting for a very long time. The other thing I don't have on here is for chemotherapy-related anticoagulation, enoxaparin tends to be the drug of choice still, just because it's really the only one that's been studied for a lot of specific chemo-related indications. So I'll just throw that as a caveat there. I think that'll change as some of the newer oral agents get more recognition in different areas, but we'll see if that happens in the next few years. Cons about low molecular weight heparin compared to heparin: it's not fast acting, so it takes a few hours to work. You can't easily titrate it. Remember, it's stuck in your body for about 12 hours. It's sub-Q absorption, which takes a while. And we don't monitor it, which might be nice because you don't have to send your patient back in. But at the same time, you have to worry about the patient. You don't really know exactly, which is it's kind of an interesting thing with anticoagulation, because a lot of the early ones like heparin and warfarin, monitoring is like a core component of giving those drugs. And to use one without monitoring, you might feel like, well, I don't really know for sure what's happening. I don't have this lab value to tell me exactly what's going on. So that can make people a little uncomfortable. Convenience is an issue. Compliance is an issue. Can people actually do the injection? We used to do a ton of this because people would come into the ED with a deep vein thrombosis or maybe a really light PE. They would get Lovenox and heparin started, and then they would leave. And so as pharmacists, our kind of role was education on this and giving them their first doses. So I've probably done 100 plus educations and done, watched a lot of people inject themselves for the first time. And I would say 95% of people really dislike that. So the convenience and compliance is tricky. Fortunately, we've gone away from this process, and we'll talk about the newer drugs here in a second. But anyway. You can reverse these products just really quickly while we're still on heparin, low molecular weight heparin. There's a product called protamine sulfate, which combines with heparin to form a neutral salt that doesn't interact with anything. It takes about 5 minutes to work. It's really fast. And 1 milligram of protamine neutralizes about 100 units of heparin. That's how it's dosed. However, heparin can rebound after about 8 to 18 hours, depending on what you might see. So monitoring is really important. It also can drop blood pressure, cause bradycardia, and have like an anaphylaxis reaction during infusion. So there are some complications that you have to be careful of. Vitamin K antagonist, aka Warfarin. There's only one drug on the market that's a vitamin K antagonist, and it is Warfarin, aka Coumadin. Jantoven is another brand of warfarin that you might hear used, but it's all the same thing technically. This is the primary long-term oral anticoagulant. I should say historical maybe at this point. I don't know if I can say this at this point. Primary, historical, I don't know. I feel like warfarin's falling more and more out of favor lately, which is good and has its pros and cons. Anyway, it's the oral anticoagulant for AFib, and venous thromboembolism has been the gold standard for anticoagulation for decades. Fun fact about warfarin: super versions of warfarin were used as rodent poison. You might hear people. I did a rotation at the VA, and I spent 5 weeks in their warfarin clinic, which sounds about as fun as you guys might expect. But the flip side is I talked to a ton of people about warfarin, and I got really comfortable with it, so that's good, I guess. But the amount of like old vets who think they're really funny and say, oh, I'm taking my rat poison, comes up quite a bit. So that's something you might hear somebody say is like a joke, right? But they aren't actually taking that. But yeah, I think at one point some rodent poisons were actually like super versions of this to cause massive hemorrhage, internal hemorrhage in the rodent, which is pleasant to think about. Vitamin K, also, if you're wondering where vitamin K comes from, the German word for coagulation starts with K. It's actually coagulation with a K, which is my fun German fact for the day. Several clotting factors are derived from vitamin K, which has to do, again, with the coagulation concept here. So 2, 7, 9, and 10. So remember, 2 and 10 are our big guys here. If you inhibit the ability of the body to process vitamin K through certain enzymes, you inhibit the body of being able to make clotting factors. So that's warfarin's mechanism of action. I've got a picture here on the next slide kind of highlighting that. Warfarin, as I said earlier, takes about 5-7 days for full effect. In the meantime, the problem is you can't just, even if somebody's low risk, you don't just want to send them out on warfarin with nothing else, because they can be at a hypercoagulable state. The problem is that vitamin K also is responsible for proteins C and S, which act as natural anticoagulants. And by starting them on warfarin, those two deplete faster than the clotting factors. So you actually cause the person to be in a hypercoagulable state initially because of that fact. After it balances out, it doesn't really matter after a few days. But in those first couple days, you're actually at higher risk for clotting, even though you're taking warfarin. So that's another reason why you bridge people on warfarin with enoxaparin or something like it. Warfarin is hepatically metabolized, CYP2C9 mostly. You don't have to renally adjust it, which is great. In fact, one of the reasons why warfarin will hang around probably for quite a while is because a lot of the newer drugs that have come out to replace it are renally adjusted and don't have good studies in patients with advanced renal dysfunction, I should say. So patients on dialysis, patients with stage 4 CKD are going to be warfarin patients primarily. So you're always probably, well, at least for several years, you're probably going to still have that niche for warfarin where we aren't going to be using the other drugs quite as much. However, that's changing, and as those drugs get studied in other populations, we might see those recommendations swap a little bit. Okay, this just highlights the mechanism of warfarin. The big thing in here is this thing called vitamin K oxide reductase, which is an enzyme that warfarin inhibits. And by doing that, it prevents this reaction with vitamin K as a kind of catalyst that causes the precursors in here. They're using prothrombin as an example, or factor 2. And that's what happens. So you can't make as much factor. You're going to make some, but not as much. And you can't shut down this process completely. The tricky part with this is you might think is this is a really indirect way to inhibit clotting factors because you're just preventing production. What are the other factors that go into production? What if you eat a ton of vitamin K in your diet? Great question, whoever asked that. We'll get there in a second here. Warfarin, because of its issues with being very indirect in its mechanism, it's dosed once daily. It sticks around in the body for a while, but dosing is really hard, and people are all over the place with warfarin. You'll see, again, working in a clinic for 5 weeks, I saw every dose under the sun. People might be on 1 milligram a day to everything from 10 to 15 milligrams a day. And they might not be that different of people. They might be relatively the same weight and age, but very different doses. Now, there are some recommendations with warfarin. I always recommend if your patient's of relatively normal BMI, like not extremely muscular or overweight, I would recommend just starting with 5 milligrams a day, get them up to where they want to go, and then going from there. Now that doesn't go with the guidelines. The guidelines will say to start somebody like at 10 milligrams and try and load them. Problem is, in dosing hundreds and maybe thousands of warfarin patients in my career, I've never seen loading work with warfarin. I don't understand where the guidelines get their recommendation, because what happens is if you try and load somebody on warfarin, you end up with an INR spike, and then it drops because you try and compensate for that, and then you kind of ping-pong the patient around until you level them out. Whereas if you start a little bit lower and go slowly, it's a much better approach. Just, you can trust me on it. You can try it yourself if you want, but that's my rule of thumb. Warfarin is also not immediately seen as far as effects go, which makes it tricky. So you might start somebody, so if you start somebody on 5 milligrams and test them the next day, you're probably not going to see any change in their INR. If you start them on 5 milligrams and check them in a week, that's too long. So you want to start maybe 2 to 3 days after you start somebody on warfarin, or after a dose change to make sure their INR is responding correctly. There's not really a rhyme or reason to warfarin. Generally speaking, the common sense applies. Younger, heavier people will require more warfarin. Older, smaller people will require less, but that's not an absolute rule by any means. I mentioned INR a couple times without telling you what that means. My bad. Monitor the international normalized ratio. INR is how warfarin is monitored. If you think about what an INR is, what it means is if you have an INR of 1, you're normal. So if you take any of us in this class who aren't on warfarin and test our blood and run it through an INR machine, it's going to come back at 0.9 to 1.1, something like that. So that means we have normal clotting blood. Essentially what it's doing, and what all clotting tests look at, is how long it takes your blood to clot. That's really it. So APTT, factor 10A, they might have different assays and stuff like that, but essentially what it's coming down to is looking at how long does it take your blood to clot. So INR, if you have an INR of 2, that means it basically double the time to clot of a normal person, 3 triple the time to clot. So what we're looking at with an INR is generally most indications therapeutically anticoagulating somebody are going to look at targeting 2 to 3. If you have somebody on a lower prophylactic dose, it might be 1.5 to 2.5, and 2.5 to 3.5. The higher range is usually for patients with mechanical valves. Most patients will require once monthly INR checks. In fact, you rarely go less frequently than that. That's a stable patient really beyond once monthly. In the beginning, you'll usually do more frequent monitoring until you nail down their dose to what you need it to be at. You monitor factor 10 in patients with unreliable INR. Some patients, just for whatever reason, their INRs are really wacky, and so factor 10 monitoring might be done. It's a percentage. And so, like, again, if I'm a normal person, my factor 10 is like 100%. It's working to its maximum capacity or whatever. But if I drop it down to 20 to 40%, that's the capacity of how it's working. So it's kind of inversely, where INRs, the higher the number, the more anticoagulated you are. CFX, the lower the number, the more anticoagulated. So if you're a CFX of 10, that's where you start to get a little nervous. And then there's something called lupus anticoagulant, which is sort of it's something that patients with lupus tend to have commonly, but also you can see it in non-lupus patients. You can do tests for this too, but a lot of times we'll see patients who don't respond or their INR is really out of whack and we don't see a rhyme or reason for it. It doesn't make sense with the doses we're giving them. We'll test a CFX level and see if they correlate. So we'll say, okay, what's the CFX? We do it and it comes back 30. It's like, oh, they're therapeutic, but their INR still says they're 1.2. So, you might see stuff like that, and that has to do with lupus anticoagulant or other factors as well. All right, I already yelled at you guys to not load Warfarin, so again, you could take my advice or go with the guidelines and see how that works out for you. The ping pong effect is dreaded. And one thing I'll say really clearly here, if you ever get involved with warfarin dosing, don't hold warfarin unless your patient's like INR pinged really high or is acutely elevated, or you're holding for a procedure. That's fine. But if you're just trying to adjust down, holding warfarin, what's going to happen if let's say they're on 5 milligrams a day and you're like, oh man, they're at 3.5, I need to hold a dose. Wrong answer. If you hold that dose, you're going to see that INR really drop later. So you want to be careful with that. The better option is to go with a lower dose. So maybe go to 2 milligrams for a couple days and then ramp back up. That's sort of my general rule of thumb. Fortunate thing for you guys as PAs is you probably won't do a lot of this. A lot of warfarin dosing in the hospital. Warfarin dosing in the hospital is pretty much all done by pharmacists in most places I've ever been and heard about. It's sort of our bread and butter, and it's how clinical pharmacy, one of the things that really started clinical pharmacy to begin with, which is kind of cool. But the other thing you'll see is there's nursing run INR clinics that protocols and stuff in the outpatient world that nurses usually follow up on. So it's not something you usually get involved with, but if your patient's on warfarin, I highly recommend just following their INR peripherally, making sure everything looks good. Okay, I'm almost done with warfarin. Gosh, warfarin's a big one. And it's funny because it used to be such a the thing, and now it's just kind of falling out more and more out of favor. We might see warfarin disappear at some point in our lifetimes. Who knows? So what's the problem with warfarin? I talk about how great it is. Well, not only is it problematic because you have to monitor regularly, and there's issues with its timing, right? It's hard to titrate it correctly. The other problem is drug interactions. There's a ton of drug interactions. Antibiotics, amiodarone, which is a really common antiarrhythmic, as we talked about last week. Lots of supplements interact with warfarin. So there are food interactions too, which is probably the worst thing. And what food are they? They're really healthy things that you want your patients to eat. So vitamin K containing foods are problematic for warfarin therapy. Specifically, green leafy vegetables, kale, spinach are kind of the two big culprits I think of a lot. The point with this, and another one of my warfarin pet peeves, is when I hear people tell people not to eat these foods, because they should be eating healthy diets with vegetables in them, and that's good for you. So if they're doing that, great. The point is to keep it consistent. You can have regular vitamin K, that's fine. We're just going to need to dose adjust for it. Now, if you go and binge a kale smoothie or something like that, that could throw you off, especially if you aren't used to that in your diet. So that's something to be careful of as a warfarin patient. But consistency is really key. Some other issues: smoking can increase warfarin's metabolism. Smokers might require higher doses, and alcohol may increase with chronic use, or as the liver in alcoholic patients who haven't destroyed their liver, their enzymes are usually at a higher functioning capacity due to the processing of alcohol. But if you aren't a heavy drinker and you acutely binge drink alcohol, you can kind of stun your liver's enzymes into not doing anything for a little bit, and then they'll ramp back up later, which can cause sort of a prevention. You don't do anything with your warfarin, and then you over metabolize it later, so it can kind of throw everything out of whack. So vitamin K can also be used to reverse warfarin. We have IV NPO vitamin K. Vitamin K is not a fast reversal agent. If you remember our whole mechanism here, the idea is that it takes vitamin K time to make clotting factors. You can give vitamin K to reverse warfarin, but don't expect any change for a minimum of 6 hours. I usually recommend people at least wait 12 before reacting, and ideally a full 24 hours. The problem is if you wait 6 hours and check that INR, you're probably not going to see a big change. Let's say they come in with an INR of 10, like, oh, they're at high risk for bleed, let's reverse them a little bit. Give them a little vitamin K, you check it in 6 hours. Oh, they're still not down, I'm going to give them another one. You end up compounding the effects, and that can last for a long time. You can end up, I've seen people who have gotten overdosed on vitamin K because of inpatient providers with suppressed INRs for weeks. And what happens in that situation is you have to be on enoxaparin or heparin to make up for the fact that your warfarin's no longer effective. If it's IV or PO, like how do you decide? IV is going to work a little bit faster, like maybe it works closer to 12 hours versus 24, but it's still not quickly because your body still has to take that vitamin K and process it. All you're really doing is cutting off the GI transit time if you give it IV. So if somebody's got active bleeding, if they've got a surgical procedure coming through, or if they're tolerating oral medications, if they're bleeding currently, surgical procedure soon, yeah, cutting off that GI transit time might be helpful, so giving them IV. If they can tolerate oral medication, vitamin K absorbs really well, probably just give it to them orally. Generally avoid IM injections, it's painful, but there is an IM formulation for infants that's specifically designed for them. That's a little different. The dose can go up to 10 milligrams. Be really careful with those high doses. That's sort of the moral of the story. When I use that 10 milligram dose, it's because the patient has a brain bleed, or they might be in liver failure, and sometimes you'll see a patient who's just not making any clotting factors. It has nothing to do with warfarin. It's just the fact that their liver's not working. So at that point, it's like, well, you can't really overdo it, so you might as well slam them with vitamin K and see if you can get them to kind of push through a few clotting factors. But those are really the only situations I use that big dose in. All right, a couple other anticoagulants. Direct thrombin inhibitors bind to the active site of factor 2, thrombin, directly. They inhibit fibrin formation and activate some factors. These are good alternatives if you have HIT risk. So for those patients with HIT antibodies to heparin, problem is they're really expensive. But two products here, argatroban, which is dosed as an IV bolus and infusion, just like heparin. It's relatively fast acting, fast onset, short acting, which is nice. So you titrate it kind of like heparin, similar. Bivalirudin has a similar dosing strategy as well, with a slightly shorter half-life even, and some renal elimination, so you might have to think about that. Bivalirudin also has some role in acute coronary syndrome. Pradaxa, or dabigatran, is the only oral direct thrombin inhibitor on the market. It was, I should change this. Sorry, this is an old bullet point, my bad. It was originally only approved for direct thrombin inhibitor. It was originally only approved for DVTs only, and now it's got much broader indications. It was the first oral drug in decades to come on the market that was an anticoagulant that could replace warfarin potentially, so it got a lot of marketing and press originally. It also, interestingly enough, has a lot of nice attributes that sound great on paper. It doesn't have any CYP interactions. It doesn't have any food interactions. It's not reversible, though. That one probably doesn't sound great on paper. Anytime you have an anticoagulant that's not reversible, people get super nervous for good reason. You want to have that fail-safe to be able to pull back that anticoagulant if you need to. In this case, when this drug came out, they didn't have that. At least nothing that was studied to be effective in that area. Half-life's 12 to 14 hours. You dose it twice a day. It's renally eliminated, and if your renal function's predictable, you should be able to rely on that. So the kinetics are very consistent. It's directly acting on the end thrombin, which is your common pathway product, as opposed to warfarin's super weird indirect mechanism. And so you can rely on this effectively. It is contraindicated for mechanical valves, so we don't use it in those patients. GI upset's probably the biggest side effect with this one that causes tolerance problems. Now, however, dabigatran is probably the least used of the new ones, even though it was the first to market, because of post-marketing bleeding risk that was pretty well documented with Pradaxa. Ultimately, not very many people take it. It's still a drug that's used here and there, and some hospitals might like it more on their formulary. And there's a new reversal agent out for it, so I say, this is old. Sorry, not reversible. This is like when it first came out. Old, now reversible. So This was reversible. I can't spell today, sorry. Reversible. I'll get this right at one point. Is that right? I don't know. I'm not thinking clearly today. So it was reversible. It wasn't reversible when it came out. Now there's a product on the market that's insanely expensive that will allow you to reverse this directly. So we'll talk about that here in a second, what the problems are with that. But anyway, let's move on to the next one. Factor Xa inhibitors, fondaparinux, rivaroxaban. Fondaparinux is injectable. It's similar to low molecular weight heparin as far as its presentation goes. This is the product that's really only used if you have a hit risk or a pork intolerance issue or something, or you just refuse to take pork for religious reasons or whatnot. That might be a product you would give somebody. Otherwise, it's kind of expensive, and we don't really use it outside of those particular indications. Rivaroxaban was the first oral factor Xa inhibitor, or Xarelto. It's got probably the most FDA-approved indications, at least when it came out, although the other ones have basically caught up to this at this point. They're all kind of the same. There's a couple others in this class. Post-marketing bleeding risk isn't as bad as Pradaxa, and maybe we will see an increased role. We have definitely seen an increased role with this product. This is a very popular drug now. And again, it's replaced warfarin in a lot of different ways, along with its best friend, apixaban, which we'll talk about here in a second. It does require renal dosing, which is a possible issue. Factor Xa inhibitor continued. Apixaban, Eliquis, is approved as well. It shows good evidence in AFib. It's used in venous thromboembolism as well. It's the least renally eliminated agent. We might actually see some studies coming out saying you can use this in patients with renal function, which would be great. Right now we don't, though. Has probably the better safety profile of any of these newer agents. So it's a really popular one. It's probably, if I had to count them, I'd probably say that apixaban is the more popular of the three new ones. So if we look at Pradaxa, rivaroxaban, and apixaban, this one is the winner for most people, and for good reason. There's a lot of good evidence associated with it compared to the other ones. It kind of edges out rivaroxaban a little bit in some areas. There's another drug called edoxaban, which isn't as popular. It's sort of newer. And then there's some other ones that were in development. Who knows if they'll come out? I think at this point, sort of like you got to be first to market and you got to have good data to back it up. And apixaban's sort of been the winner. And I don't think other drugs are going to have a hard time matching the amount of evidence and good safety profile data that apixaban's racked up. And these weren't reversible for a long time. So again, these have the same issue as dabigatran did when they came out. It's like, hey, we got this oral agent, but by the way, it doesn't reverse. And people are like, I'm good. I'm not going to use that because I trust warfarin. I know how to use warfarin, and warfarin is reversible. These are not, so I'm not going to use them. Now, there is a specific reversal agent. Whether that's a good thing or a bad thing, I will talk about in a second. Okay, so let's spend a little bit of time, because these drugs are becoming so popular, talking about these drugs, the target-specific oral anticoagulants. These have been called a lot of things: TSOAC, DOAC, NOAC. I kind of like DOAC the best, direct oral anticoagulant. TSOAC is target-specific. NOAC is new, which doesn't really mean anything anymore because they aren't really that new. Been around for, gosh, I think the first one came out when I was, dabigatran, I think, came out when I was in my last year of pharmacy school. So that was 2010. And kind of starting my rotations is when it first came out. So they've been around for about 10 years now. So not new anymore, really. So again, a lot of these studies, to make their product marketable, they had to go head against warfarin. That was the big target here. If you want to treat AFib and VTE, you got to be better than, or at least as good as warfarin. So these studied drugs basically needed to show non-inferiority to warfarin, which they did. One of the controversies with some of these studies is that these drugs looked at comparing themselves to people in groups where their INR was in goal about 60% of the time. Now, a good warfarin program has statistically can put somebody in goal 90% of the time. So whether that was a big controversy at first, people were like, well, my warfarin clinic has 95+% goal. We're pharmacists managed. We're excellent standard of care, yada, yada, yada. We're way better than 60%. So clearly that doesn't apply to us. So there was some controversy with that. The no dietary restriction thing was, I think, universally liked. Everyone hates the dietary restrictions of warfarin. That's a huge plus. Ideal patient for these products: you aren't elderly, you have great kidney function, or at least okay kidney function, relatively normal weight. We'll talk about that in a second here. Poor access to lab facilities, maybe you're reliable, compliant, but you live in the rural community where you have to drive an hour to get to a clinic. Lack of reversal development is a major barrier. Some are currently in development and are developed. Sorry, I should really proofread this lecture, but it's fun to do this in real time too. No monitoring. Again, we talked about this with low molecular weight heparin. Some people think this is a pro. Others say it's problematic. And then cost. Oh man, you're probably thinking, well, these are new, right? Aren't new drugs expensive? Yes. These are more expensive than warfarin. In fact, if you take into consideration the monitoring and lab visit costs with warfarin, these are still more expensive than warfarin. So that's a big, I think basically what it comes down to is like warfarin with lab monitoring, maybe like $100 a month, something like that. These drugs are probably $200 to $300 for a monthly prescription. There's a lot of cool coupons and stuff out there though, so we'll talk about that here in a second, I think. Trying to remember to come back to that if I don't. Okay, approved indications. As you can see, most of these have approved indications for basically everything we'd want to use them for. Different dosing, though, which makes it a little complicated, but there it is. Ooh, a complicated table with a bunch of numbers on it. You guys love these, right? Don't memorize this. There's no reason to. This is just, I hope this is helpful. I would really recommend kind of looking through this and trying to process this a little bit as you're thinking about these, because these are super popular drugs. You're going to see them in every facet of practice, basically. So, and you're going to see warfarin really commonly as well. So knowing kind of the basic differences is important. You'll notice, I'm just going to point out some things I think are interesting. Warfarin's once daily. The other ones are all twice daily, except edoxaban and rivaroxaban. Funny thing is, let's compare that to apixaban. Apixaban's half-life is actually longer than rivaroxaban, but it's twice daily versus once daily. So I think the drug makers, I don't know, maybe in their animal studies or in their phase 1s or whatever, they figured, well, we know our drug doesn't last that long, but the sustained effect of the anticoagulation probably goes beyond this inhibition. So the drug stays in the system for a little bit, but it might keep that clotting pathway inhibited beyond that effect, which I hope it would, because if you lose it completely during the middle of the day, then it's like, well, what's the point of taking it? So I don't know. I think that's kind of interesting that the half-lives are similar, and they really do basically the same thing, but the dosing's different. Well, so again, why I don't know. Maybe it was a gamble taken by the drug company side. I don't know, to make a more compliant or a more convenient method of administration. Some administration pearls, with or without food, can always make a difference. Warfarin is contraindicated in pregnancy. The other drugs all have no real pregnancy data out. However, apixaban had some okay animal data, which is category B, meaning that it showed that it wasn't detrimental to the fetus of developing animals. Pregnant patients don't really line up for clinical studies, nor do we test that because it's unethical. But over time, I think we might see some of this get used for different pregnancy indications. Right now, basically for pregnancy, you do low molecular weight heparin injections or regular heparin injections, so you're injecting every day, which is not convenient. So having one of these options for a pregnant patient, and we haven't talked about women's health and hormones and things like that, but the increased level of estrogen during pregnancy puts people at high risk for venous thromboembolism. And so to be able to treat that with a convenient oral drug that's not harmful to the fetus would be huge. And right now we just don't have that evidence to say that that's okay. Someday maybe. Reversal agents. 2 on the market. We have idarucizumab and adanexate alpha, end of 2017. It's on the market now, so ignore that part of it. Yeah, and I'll talk about these in a second specifically. Expected outcomes. Again, I don't care that you know this. If you want to look at this a little bit, I gave you these slides. One of my colleagues put this together, and I think it's an interesting way to look at the different data where they found changes compared to warfarin and what they studied against, which I think is interesting. Again, I'm not going to test you on this. The point is that apixaban, rivaroxaban, they look pretty good against warfarin if you look at the overall trend compared to bleeding risks and outcomes and everything like that. Major bleeding. Renal considerations. This is a nice chart that kind of lines it up. Again, not going to test you on this. I think it's a nice reference, though, if you're wondering, gosh, where do these go, blah, blah, blah. Who can I use and what? And then it sort of has it all there. Apixaban has some kind of interesting criteria, too, which we'll, I think, get to here in a second. Hepatic considerations. Again, A lot of information I'm not going to test you on, but good to know. Good to look over and kind of understand the differences. Basically, there's not a lot of adjusting we do for hepatic dysfunction, but it's there. Age consideration. The really big one to look at here is the green apixaban. Apixaban actually has a specific recommendation for age because exposure increases over about 30% in patients over 65 years old. And age is actually, again, incorporated into the dose adjustments. The rest have some age things that you can look at here, but apixaban actually put that into their recommendation. Apixaban also, whoops, where's the next one? Has a weight recommendation. So less than 50 pounds had an increased exposure. Over 120 had a reduction in exposure. So apixaban actually has 3 different criteria, which is kind of unique for it. Instead of recommending you dose it based off of just creatinine clearance, like the vast majority of drugs there, they say, okay, you have to meet 2 or 3 of these criteria. You have to be, if you're over a certain age, if you're under a certain weight, and if you have a creatinine of less than XYZ, and I can't remember these off the top of my head. I apologize. I don't dose apixaban very often. But the point is there's very specific criteria that say for apixaban, there's 3. You have to meet 2 of them, and then you dose reduce. So it's very different from the rest of it. And it's probably I think it's a really cool approach to dose reduction because I think I kind of applaud this drug company. I can't remember who makes apixaban, but for actually taking the time to make a recommendation like that and look at multi-factors when it comes to weight reduction. Because I don't know, you could maybe make an argument that because they took that novel approach to it, it might be why their side effect profiles and their safety profile is as good as it is, because you're looking at things outside of just renal function. Now, the other argument is that the other drugs don't need to because they don't have the bigger considerations. But anyway, apixaban seems to be doing better overall. Drug interaction considerations, again, for your information. Ultimately, pros and cons. Let's talk about this slide. The big take-home message of your DOACs. You have no INR checks, no diet restrictions, less severe bleeding, fewer drug interactions, easier pre-op management. You don't have to bridge with heparin or low molecular weight heparin. Nothing. You can start somebody on a DOAC the day you want to treat them and send them home. That's it. Nothing else, which is great. Disadvantages, they're more expensive. Not approved for every indication. Remember, our valvular, AFib, and renal dysfunction patients still are going to be warfarin for the most part. Compliance. Compliance, you might think, well, shouldn't that be an advantage? They're easier to take. You don't have all the food stuff, yada, yada, yada. Problem with compliance is that if you miss one dose of this, you're basically not covered at all. If you miss a dose of warfarin, you still have those circulating clotting factors are still suppressed for a couple of days after you miss that dose. So for people with issues missing doses, DOACs probably aren't a great choice. Warfarin's actually probably better for those patients. Higher discontinuation rate compared to warfarin. This mostly stems from dabigatran studies and the dyspepsia caused by them. Dose adjustments needed for renal dysfunction. Okay, that's of course a problem compared to warfarin. And no data in dialysis or advanced kidney patients yet. I shouldn't say there's no data. There is some data. There's not enough to really move the scale or move the needle. That's the right term. All right, our mechanism of action for idarucizumab is the reversal agent for dabigatran, which was studied, and there's a bunch of information here I'm not going to test you on. I'm not going to actually test you on the name of this drug. I don't care you know it. It's called Praxbind is the brand name, which is clever. Pradaxa, right? Binds Pradaxa. Tells you the mechanism and the name. I'm always a big fan of drugs that tell you the mechanism and the brand name. It's great. Praxbind. Binds Pradaxa, neutralizes activity. Done and done. Adenexant alpha is a biologic modified recombinant factor 10A derivative and does basically the same thing. It binds to factor 10A with higher affinity factor 10 inhibitors bind to it with higher affinity than they would to factor 10A. So it kind of like almost think about it as like sucks them up like a vacuum cleaner. Not really a good analogy, but you get the point. Reverses very, very quickly, as studied with both apixaban and rivaroxaban. Similar yet different dosing strategy. Different doses yet similar strategy, I should say. Other reversal options, fresh frozen plasma has a bunch of clotting factors in it. It's effective to getting the INR down a little bit, but below like 1.8, you probably won't do anything. And you need a ton of plasma. It's a lot of volume. So if your patient's volume overloaded, it's not going to be it's going to be a moot point to begin with. And it's slow to prepare. It's just the only thing it's good for is probably external trauma bleeding, as it provides volume. If you need that reversal plus volume, there you go. But otherwise, it's not commonly done. At least not in my experience, I should say. For just like an average reversal, I should say. Not if you're in a trauma center, it's probably much different. Prothrombin complex concentrate, or PCC, is Kcentra. Kcentra has been the warfarin reversal standard for a while. It works extremely fast, like with basically instantly. So we do a recheck INR after we give PCC at like 30 minutes, and it's always like 1. I've never seen it not drop completely. Like going from 10 to 1 in 30 minutes is pretty cool. Basically, you're just giving a bunch of activated clotting factor to the patient immediately. It's really expensive. A full dose of PCC is about $25,000. It's a blood product, so it's like they isolate this from human blood components. So when you donate plasma, this is where they're getting it from. 2 indications: acute major bleeding and urgent surgery or invasive procedures related to warfarin reversal. Now, the caveat with PCC is because it took a while to get these 2 drugs on the market, dabigatran reversal and factor 10A reversal, we use PCC because we're like, hey, it should theoretically work because it's clotting factor, and we don't have anything else. Someone comes in with a neurologic trauma or a head bleed or something, and we have to give them something to reverse it. Well, we're going to try this because we didn't have anything else. It turns out the evidence we looked at for patients specifically at our hospital who were treated with this, the outcomes were actually better than the data that the trials used to push these 2 drugs to the market. At least, sorry, I should talk about these separately. Idarucizumab, dabigatran, doesn't really reverse well with PCC, so that's different. Adenosine alpha, factor 10A products, so apixaban, rivaroxaban, reverse really well with PCC. So because this product is more expensive than PCC, yes, it's like twice the cost, which is insane. And because we're used to PCC dosing, we just do PCC dosing. We actually don't use this product as a formulary agent. We've got good data to show that PCC is as effective, if not more effective, than the newer products. So kind of interesting. We waited all this time for this adenosine alpha, and turns out it's not even that great. All right, thrombolytics. So unlike antithrombotics, these products actually break clots down. If you want to destroy a clot, a drug like alteplase, rectoplase, tenecteplase work. We're going to talk about these more with stroke, but they can be used with heart attacks, which I talked about last week. Okay, just a brief kind of review, just so we're clear on this, because this isn't really covered specifically in any of the other lectures. But as far as venous thromboembolism, I just want to talk, I would encourage you to pause this lecture and think about, based on the information I get, how would you approach a deep vein thrombosis or a pulmonary embolism, and how would you treat that specifically? We talked about AFib in the last lecture, which has a bunch of anticoagulation components to it, but this is a little bit different. So a DVT and PE are treated the same way for the most part. Now, PEs have varying grades of severity, and so the way you might treat a submassive versus a massive, we're not going to get into that. I'll come back to that during emergency medicine a little bit. But the point is that you want to get somebody anticoagulated relatively quickly. So if it's a serious PE, you're going to give them IV heparin and probably admit them. Everyone else, even with minor PEs, and in fact, when I first started practicing in the ER, we never discharged PE patients, but that practice has changed within the last, 5-6 years, where we now discharge people with PEs who are relatively stable otherwise. So because of that, we would always do Lovenox warfarin because those were our only options. And even when Pradaxa came out, it still wasn't loved very much, and no one really moved the needle on it. When the factor 10As came out, we started seeing data saying, hey, the bleeding risk is lower, they're good, if not maybe better than warfarin. And then insurances started paying for them. That was the other big nice effect. And so that's what I was going to get at quickly here before we sign off, is that when you're treating these, a lot of times you're now just going to start somebody on a DOAC, and that's it. You can set them up on rivaroxaban or apixaban. Usually it's whatever their insurance pays for. Insurances probably will cover one or the other, maybe both, but pretty much all the major insurance plans are covering them now, which 5, 6, 7 years ago they weren't. So we always had coupons we'd have to give people that would allow them a month supply, which gives the pharmacy time to figure out like an authorization process for the drug, which is a whole bunch of work. Now they pretty much cover it right off the bat. If you ever have any questions and you're going to prescribe one of these products, which, by the way, if you're going to prescribe one of these products, you should always have a question about this because insurance coverage is tricky. I can't tell you how many calls I get in our ER from providers who have left for the day or overnight or 2 days ago, I should say, that aren't there anymore. And now it's like, hey, this person provided rivaroxaban, it's not covered. Can they do apixaban instead? Well, the answer is yes, but it's like the pharmacy has to call and clarify that. So doing that homework first, contacting your pharmacy. You can ask your pharmacy to run a test claim for you. It takes like 2 seconds. Basically, they just plug in the patient's information, do a fake prescription, it sends it to their insurance, and they see if they get a paid claim or not. And that's really all there is to it. Again, it takes a few seconds, and it saves everyone headache on the back end. You can do it. You could maybe triage this to a nurse or somebody else to call and ask. But the point is to try and get that taken care of before you send them out with a prescription, and then you have to do it on the back end. It's a lot easier to do that right away. So dosing the DVT or treating the DVT or PE, again, if you're discharging somebody, you're almost always going to do a DOAC. There's really not much reason not to at this point. And we've proven pretty definitively that you can reverse a DOAC with your PCC protocols, and so that's not as big of a concern as it used to be. So I'm a big fan of DOAC specifically. I think rivaroxaban and apixaban, for all intents and purposes, are essentially equal. Apixaban probably takes the edge in safety and has a kind of a bit more novel approach to dosing adjustments. But other than that, I would be comfortable with either one in myself or a loved one recommending. Pradaxa, I'm a little bit hesitant about. I don't think its safety data is as good, and I don't think its efficacy data is as solid as the other two. But that's my personal opinion. So if that wasn't working, or maybe their insurance only pays for warfarin, Lovenox and warfarin is the way you're going to go. You're going to start them on a warfarin dose. Again, 5 milligrams a day is a good place to start if you're kind of stuck. And then dosing their enoxaparin weight-based. 1 mg per kg every 12 hours. Give them a week's worth. Make sure they're following up with an INR check at their clinic within 5 days. Usually I'd give them like 30 days, 30 count of warfarin, 5 milligram, and then they can kind of titrate and adjust based off of that. So if you're treating ongoing warfarin, you'd probably be very familiar with dosing and the movement with warfarin. So you might have people on different doses, different days. It's really common with warfarin. You might have people taking 2.5 milligrams Monday, Wednesday, Friday, 5 milligrams every other day. So splitting tablets, partial doses, that kind of stuff is really common with warfarin therapy. All right, any questions, let me know. That's it for this particular lecture. Thank you.